Okay, I believe we can go ahead and get started with today's event. Um, and first off, welcome to today's webinar, which is entitled Patient-Centered Real-World Evidence, Recommendations and Use Cases. My name is Dr. Rachel Hendricks Stirrup, and I serve as Research Director of Real-World Evidence at the Duke Margolis Center for Health Policy. This webinar is co-hosted by the National Health Council and the Duke Margolis Center for Health Policy as part of our joint effort to educate the health stakeholder community on real-world data, real-world evidence, and also patient engagement. Next slide, please. Before we get started, I just want to point out a few housekeeping items and notes. This webinar will be recorded and made available later on the NHC website after the event concludes. All attendees are automatically muted and cannot unmute themselves throughout the duration of the event. We will have time at the end of this webinar for questions and answers. So please submit any questions through the Zoom's Q&A function. Next slide. Happy to introduce myself one more time. As you see my picture here, I'm Dr. Rachel Hendricks Stirrup, Research Director of Real World Evidence. I'll also like to introduce our speakers for today. First, we have Dr. Elizabeth Earline, who is the Assistant Vice President of Research and Programs at the National Health Council, or NHC, as I've noted for short. She's a mixed methods researcher with an interest in developing methods for patient experience mapping and applying patient insights into drug development, value assessment, and real-world studies. She's an active member of the International Society for Pharmacoeconomics and Outcomes Research and holds leadership roles in the patient-centered and real-world evidence special interest groups. Next, we'll hear from Dr. Mehmet Burcu, who is a principal scientist and director in the Department of Epidemiology at Merck & Company Incorporated. In his current role, he works with large automated database studies, as well as global multi-country real-world data studies to support clinical development and regulatory decision-making. He has published extensively on a wide range of pharmacoepidemiology, drug safety, policy, and real-world evidence topics. Next slide. Okay, so I'll give this all a webinar overview. So during today's webinar, I will first introduce the real-world data and real-world evidence training series in a virtual classroom at the Duke Margolis and NHC, who co-developed this over the past 1.5 years. And next, Dr. Earline will introduce a set of consensus recommendations on developing patient-centered real-world evidence. Then Dr. Burcu will describe a set of illustrative examples on how patient insights can inform real-world evidence research. Next slide. Now, in case you did not participate in our live trainings over the past 1.5 years, please find a list here of previous webinars in our real-world evidence and real-world evidence training series listed on this page. If you're interested in learning more about this subject, you can visit the NHC website to view archived versions of the webinars, so feel free to do so at your own wish and whim. Now, in addition to the trainings, we developed a real-world evidence classroom, which includes plain language, glossary, infographics on real-world evidence, and other materials related to today's topic. Now, without further ado, I will turn it over to Dr. Earline.
Great. Well, thank you so much for that introduction. And I do encourage folks to take a look at the classroom if you haven't already. There's lots of great resources up there. And I'm excited today to introduce one of the newest resources that's up there, which is a set of consensus recommendations for developing patient-centered real-world evidence. So during today's presentation, I'll be describing a little bit about the background and rationale for why we developed those recommendations, how and our process, the methods for how we develop them, and then finally I'll highlight just several of the recommendations, and then Mehmet will put those into context through some use cases and real-world examples of what that can look like as part of a research study. So next slide, please. First of all, I'd like to start with a number of acknowledgements. In particular, I'd like to thank members of the project team who contributed lots of time to this effort, as well as our advisory board members who have been involved throughout. You'll be hearing from one of the ad board members, Mehmet, today. And then I'd also like to thank our research funders and supporters. This project received actually very, very early on pilot funding from the Patients Program at the University of Maryland for a little bit of a proof of concept. And then we had the larger research project was funded by the Pharma Foundation, and the NHC's Real World Evidence Initiative is sponsored by Amgen and Lilly. Next slide, please. So to start off, I'd like to provide a little bit of background for folks, because I understand that we may have folks who are very active and engaged in patient engagement involved in this call or participating in the call. And we may also have many folks who are very involved in real world evidence and real world data. But as both of you, two disparate groups know, the folks rarely come together to talk. So let's provide a little bit of background about this project. So as you know, interest in real world data and real world evidence among healthcare stakeholders has grown significantly over the past 2 decades. And real world evidence has a range of uses, including to guide clinical, regulatory, and reimbursement decisions. It's used in clinical practice. Real world data is used to derive algorithms that can be used at the point of care, actually, to identify patients most likely to benefit from a treatment or other intervention. And it's important to understand that traditionally real world data sets track insured individuals' interactions with the health system. And so while real world data is a powerful tool in documenting patient interactions with the healthcare system, there are a number of well-known limitations. Among those is a lack of context regarding whether or why subjects might delay treatment. If they're non-adherent, why are they non-adherent? How non-adherent are they to their care plan? And also, what's the impact of all of the things that's happening outside of the health system on their adherence, on their satisfaction, on experiences, and also on health outcomes that they're achieving? And so there's a variety of initiatives to improve the data landscape. There is lots of work being done in terms of linking and curating new data sets. Many of those include patient-generated health data. Some include also patient-reported outcome measure data. And these data methods advances are already working to improve the quality of real-world evidence, but they don't get specifically at individual patient experiences or sort of broad experiences across the population, which can be learned by engaging patients directly. And so a complementary but underutilized approach to enhance the quality of real-world data studies would be to engage patients to learn about their experiences, learn about their perspectives, to understand what's happening outside the healthcare system that influences what we're seeing in data sets. And so next slide, please. So you can see here that we have many best practices. We've got best practices about patient engagement. How do you engage patients well? And there are many folks, qualitative researchers, others who are involved in patient engagement work. Separately, we have many best practices for developing real-world data studies. And we also have recommendations that we should be doing a better job of linking the two. This is a quote from the ISPOR-ISB Joint Task Force on Real-World Evidence in Healthcare Decision-Making, which states that including key stakeholders, including patients, in designing, conducting, and disseminating real-world studies. But we don't have a set of recommendations that can help us bridge the two fields and can provide some transparency and also recommendations for researchers who are developing real-world data studies in order to identify and then integrate insights from patients as they're developing their study design. Next slide, please. And so that's what we set out to develop, would be a set of emerging recommendations, since of course these will need to be tested over time and refined, but a set of recommendations that could be provided to stakeholders involved in real world evidence development, describing how they could take information stemming from patients, patient provided information that would be gathered by researchers active in patient engagement, and how could they translate that into more patient-centered real-world data research designs that reflect patients' lived experiences. And so over the past couple of years, this is the way that we got to the recommendations. So first of all, we established an advisory board. It's a multidisciplinary advisory board, which included folks from the patient community, experts in patient engagement, as well as methodologists who are very active in developing real-world database studies. Then we conducted a series of interviews, which I'll highlight on a subsequent slide. And then we analyzed those, the information stemming from the interviews. We analyzed it, drafted it into recommendations, conducted an eDelphi survey, with a larger set of experts. And then we came out with recommendations version 1.0, which is available on the website. And certainly the advisory board provided input and regular feedback throughout this entire process. Next slide, please. Great. So this was a little bit of an interesting process. I wanted to provide an example of how did we get to these initial set of recommendations through an interview. So there's a lot of text going on this slide, and if you're interested, the white paper provides additional detail. But essentially what we were trying to understand through these interviews is if you had information that somebody else could have collected, in this case, it was actually information from an FDA project, a Voice of the Patient report that came directly from patients. And then you gave that patient provided information to researchers who develop real world database studies every single day. How would having that additional information change their decisions in terms of conceptualizing a study, designing a study, and then ultimately translating and disseminating the findings from a study? And so this was an example. We came up with 17 different scenarios that were at least 3 researchers received each of the scenarios, but it included background information on the therapeutic area, which I haven't listed here, as well as a particular piece of patient provided information. So this example is with regards to female psoriasis patients, and it's commenting how many patients say that hormonal changes impact their psoriasis. And so there's a variety of different times in a woman's life when that might impact them, and those are outlined here. And so the question was that we placed in front of the researchers was to ask, if you were designing a study to evaluate outcomes associated with psoriasis medications, and it was a retrospective cohort study, so you're using data that already exists, you're not going out and collecting new data, how would you try to integrate, would you at all try to integrate this information? And if so, at what stages would you integrate the information? And so in order to keep the results from the interviews consistent, we developed a real-world evidence research design framework, which is really tiny here, but it gets at creating a refined research question, developing a protocol, and then translating information. Next slide, please. So based on the information from those interviews, we analyzed them, and we came up with an initial set of draft recommendations. We worked with our advisory board to refine those recommendations. And then what we did was we invited an additional set of researchers and other experts who use real world evidence or real world data, their day-to-day life, as well as folks who are involved in other types of patient-centered research. And we said, these are the draft recommendations that we came up with based on those interviews. Do you agree with those? To what extent do you agree with them? And then do you have suggestions for how we can make sure that these are actionable, that they're specific enough, and that you could, actually use these, maybe not in every single study, but across different studies that you're developing. And so for folks who aren't familiar with what an e-Delphi survey looks like, this is essentially a snapshot of the anatomy of what one can look like, where it lists out the draft recommendation. And then you've got strongly disagree, disagree, agree, strongly agree. You've got then the recommendation, specific comments, so folks are able to provide specific feedback on that particular draft recommendation. And then there's also opportunities to provide more general comments and suggestions. And so we went through one round of this. We went back, we revised, we edited the recommendations, and then we went back to the same group again and asked, what do you think now? Have we gotten closer to being being at a good place in terms of the recommendations? And we had set a certain level of agreement that we wanted to achieve before we started the study. And what happened was, after the second round of surveys, we had achieved that level of agreement. And so we refined them slightly from there just for clarity, based, sort of traditional editing. But those are the recommendations that we've put out and that are available on our website. You can go to the next slide, please. So here's the white paper and a link to the white paper. And since there's a number of recommendations, there's 13 of them, I'm not going to highlight every single one of them during today's webinar, just due to timing, but I'm certainly happy to connect about every single one of them separately. But let's go through and highlight just a couple of them. Next slide, please. Great. So the first one is with regards to developing a patient-centered research question and study design. And so here's just one example of a recommendation. That's just a piece of it, but an easy way to make your real-world studies more patient-centered is, as you're doing the literature review, simply include terms to retrieve qualitative research. And so this is something that can be done without adding cost, and it's something that can be quite impactful. And it's important to note here that this is retrieving research that's already been completed by others, and we wouldn't want researchers who are doing real-world studies to think that they need to always be the ones directly engaging patients, but that there are a number of resources already published that they can rely on. For example, here's a method if you are interested in retrieving qualitative research from the peer-reviewed literature. There's a really nice guide from the University of Washington about finding qualitative research articles in PubMed. They provide a lot of good mesh terms and other suggestions for how you can do that. There's also a lot of great literature out there. I had described previously that we used FDA's Voice of the Patient reports when we were developing the scenarios. Those are also a great source of information for other researchers, and there's dozens of them. So I recommend taking a look at those. There's also a lot of great resources about patient experience maps, patient journey maps on patient organization websites, and other surveys that they feel at studies that they've done. And then finally, if you are interested in primary data collection, we also have been working with our members over the past couple of years to develop a patient experience mapping toolkit, which can help you gather experiences before getting a diagnosis, while getting a diagnosis, and then patients' experiences living with a diagnosis. And those are all available for free for folks who are interested. Feel free to reach out. Next slide, please. So then this is another recommendation, and you'll see how this looks in use cases during Mehmet's presentation. But this is, really thinking about study designs, and this is just an example, but really consider how patient input gathered during the lit review, and if you develop a corresponding conceptual framework, can contribute to study decisions, including how to define and operationalize all of these different elements. Through the scenarios, we found great examples when a piece of patient-provided information might assist in identifying a subgroup that could be of interest, whether it's part of the main study or part of a sensitivity analysis, in terms of thinking through comparators, refining study periods, exposures that might be happening outside of the health system and considering what that might look like, as well as defining the exposure for your particular study. Thinking differently about what the outcome of interest might be based on certainly your data availability, but then also what patients tell you that they want to learn more about. And finally, covariates and confounding and confounders as well. Next slide, please. Great. And then this is a recommendation simply about, disseminating research findings. And again, this sounds pretty obvious, but we see all the time in publications that this isn't being done, where if you have patient provided information, which often illuminates a specific study confounder, and if you aren't able to account for those confounders in your statistical analyses, then those should be clearly described as a study limitation. So rather than relying on a blanket statement that you're using existing data, you're using administrative claims and so on and so forth, and so you've got the regular missing data, say exactly what you mean, and maybe that would be part of try to have that in the main text, but certainly have that available to folks in any presentations that you're giving, so that it can help the end users really interpret what are your results really, and how generalizable are those to patients in their particular population. Next slide, please. Great. And then finally, just one other one that I wanted to highlight is that, it's really important that this isn't just about patient engagement. That should be guiding, and we shouldn't be using others' input as a proxy for patient engagement, but certainly we want to recognize that multi-stakeholder collaboration is essential to get this right. Physicians, nurses, physical therapists, pharmacists, and others have frequent and direct contact with patients. Don't think about that as a substitute for patients, but it's valuable information for placing the data points into context and making sure that, that we're doing a good job with study designs. And then one untapped resource is also medical coders, who can help researchers navigate data anomalies. They can help you think through if there might be some upcoding happening or what's going on in your data set. So if you work in a health system, you probably already have medical coders on staff that you might be able to engage as part of your study design, just to get these studies even more precise than they might be. Especially if you're a newer researcher who might not have the resources of industry, of other companies who may have medical coders on staff. Next slide, please. Great. And then I just wanted to highlight a couple of additional resources that we have. I also listed my email if you have any questions. I've listed out the link for the white paper, as well as a case example that we worked with some partners on. That's actually an AFib patient advisory board case example, thinking through in a particular therapeutic area, what could engaging patients in real world evidence look like. And then finally, another paper about general patient community perspectives on real world evidence. So to understand also what are patients thinking about how RWE is used, and also what do they think of in terms of the hallmark characteristic of what needs to go in for real world evidence to be reliable. So I will turn it now over to Mehmet to walk us through some use cases.
Thank you, Elizabeth. Very nice presentation. And before we move on and I present some of the use cases, first, I would like to send my sincere appreciation and thanks to the National Health Council and to the Duke Margolis for organizing this webinar on this very important topic. So Elizabeth presented a very nice summary of the recommendations from the experts who took part on the project. And as summarized and as she alluded to, and I would like to reiterate, one of the main conclusions is that high quality real-world data studies and real-world evidence evaluations should not be conducted by real-world data researchers in silos and with real-world data sources alone in itself. Instead, they should be a product of meaningful engagement of relevant key stakeholders, including patients. And as she also mentioned, in some cases, PPI, that is patient-provided information, may be already out there in the literature and in other public domains for us to utilize and establish patient-informed and patient-centered study designs. So to illustrate this point, I'm going to spend the rest of the time to discuss 4 selected hypothetical, of course, use cases where PPI can improve real-world evidence designs and interpretations. Next slide, please. So as you can see on this slide, the first use case is to illustrate how PPI can be used to understand the actual start date of the medication exposure. You may be wondering that, this is rightly available, but I will be presenting a specific use case where you really need patient-provided information to understand that. The second one is to understand unmeasured confounder distributions between treatment groups when you're conducting comparative effectiveness or comparative safety study, if you will. The third one is identifying endpoints or outcomes when you are trying to establish a study relevant to patients and caregivers. And last but not the least is when PPI can be used to understand reasons for treatment discontinuation in medication adherence studies. And I should mention that as a disclosure, these use cases are not all encompassing. They're just high-level examples about how PPI can be important to improve traditional epidemiology studies. So there are many more beyond these 4, but let's deep dive into the first one. Next slide, please. So in this hypothetical example, let's assume your main study objective is to assess comparative effectiveness of different medications from the same class that include both brand name products and generic products. Such epidemiology studies, as we know, increasingly rely on using large computerized administrative healthcare databases, such as medical insurance claims. As we know, insurance claims are excellent and great data sources to capture medications that are dispensed and paid by patients' insurance, but they're not that good at capturing medications provided as samples because insurance doesn't necessarily pay for them. Medication samples are given by physicians to patients, usually for a short period of time, for multiple reasons. This may include finding optimal dose or assessing tolerability before patient begins a long-term medication plan. One important note is that literature shows medication samples are more common for brand products than generic products, if you will. So keep that note in mind, and let's go to the next slide to present a use case. So I found this very interesting methods paper done by a very established pharmacoepidemiology group that shows that there's an indirect evidence of sample use among new users of statins at the time of the study. Statins are medications prescribed to lower your high cholesterol. So let's look at the figure on the right-hand side in the slide. I copied from the paper. Citation is there. The index date is defined as the first date you see for a paid dispensing, meaning paid by the insurance of a medication, statin in this case, in the insurance claim data for a patient. And what the researchers showed that for patients who initiated treatment with brand name medications, their LDL cholesterol levels started decreasing 15 days before, on average, before the first paid prescription date that you see in the insurance data. But at the same time, the same thing did not occur for patients with generic products. So you may be wondering why. So this really does provide a clue that some patients may be receiving samples before they start their long-term treatment plan, because it's evidenced by decreasing LDL levels, meaning that it suggests some patients may start actually ingesting the product way before you see in the insurance claims. Then I searched literature for others and found lots of actually patient and physician surveys reporting on the same across multiple medication classes, not only for statin, but in other therapeutic areas as well. So the main point is that if we do not seek for PPI, we may not have noticed these details and we could have designed our studies inadequately. Now, knowing this, I will need to assess direct or indirect evidence of this. And if it is a suspect, then I will probably need to make modification to the design regarding the index date or conduct additional sensitivity analyses to ensure that index date definition is actually reflecting the actual start date of the medication exposure. Index date in epidemiology and in outcomes research is really an important concept, because this is when you actually start the clock to look for outcomes and changes in patients' medical outcomes. So let's go to the next slide and discuss another use case. So PPI can also be used to help us understand unmeasured confounder distributions between treatment groups, as Elizabeth already mentioned in one of the recommendations. Why? Because in the absence of randomization, studies that use large administrative healthcare databases may be prone to confounding, especially if risk factors that are important for your study are not captured in these databases. And there can be multiple. These may include, of course, depending on the research question, as you can see on the slide, smoking status, alcohol use, over-the-counter medication use, and education status. So the paper I cite on the right-hand side does provide an excellent framework on methods as to how to do adjustment using this external information, including patient-provided information on unmeasured confounders in your studies using healthcare databases. But let's go to the next slide to illustrate a related high-level example. So in this example, researchers wanted to compare a cardiac-related outcome, I believe heart attack, between selective and non-selective NSAID analgesic use among older adults. And they used administrative Medicare claims database to assess the study question. So as we know, and as we discussed before, there are many risk factors are not available in claims data sources. Such, for example, for this specific question, being a smoker, being overweight, or using aspirin, which is an OTC medication, may also independently impact your cardiac outcomes, regardless of your other medication use. But the issue is that, as mentioned, these important variables, parameters, are not usually available in Medicare administrative claims or other related administrative healthcare databases. So the researchers used an external data source that directly gathered the information from patients. So this database that they use is called Medicare Current Beneficiary Survey, namely MCBS. So a brief summary on MCBS. It's a continuous multi-purpose survey of a nationally representative sample of Medicare population. It includes a rotating panel design. It has approximately 4 panels active anytime, each panel representing about 4,000 participants. So in a given year sample, you should have about more than 10,000 patients, if you will. So it doesn't include everybody in Medicare, but includes a nice representative sample of Medicare beneficiaries that can give you some understanding about patients' lifestyle or characteristics or health status, functioning related items within that population. The information that is not available in the administrative claims portion. So by using MCBS and PPI from MCBS directly and indirectly, they found that distribution of these unmeasured confounders among different groups did not differ drastically, actually. So that was a good news for them. For example, obesity was 24% versus 24%, exactly the same distribution. Smoking, yes, slightly different, but not that much to severely impact or bias your study design. However, if it happened that they were different, in all likelihood, the researchers, I believe, were going to conduct some additional adjustment using the methods and approaches, including the ones as described in the paper I cited in the previous slide. So it's important to check additional external information, including PPI, to improve your traditional epidemiological design approaches. And in this case, we pay so much attention to confounding and unmeasured confounding. And it's not always the data itself that you're using in the original source of data, but it's always to look for additional external information to help you improve unmeasured confounding. So let's go to the next slide. Okay, now let's switch the gears a bit and talk about endpoints and outcomes. Suppose that you're interested in conducting a treatment patterns and outcomes type study, which we usually do, and in children diagnosed with ADHD, which stands for Attention Deficit Hyperactivity Disorder. So you may ask yourself in the beginning of your planning, so what outcomes should you study? So in getting ready for this presentation, I did a quick and dirty literature search, not a systemic one, but quick and dirty on this to see if there are any related PPI, patient-provided information out there. And I should say that there were tons out there, but I'm only highlighting just 2 papers here. So a little background on these 2 studies. So these studies are funded by National Institute of Mental Health and NIH, which is a US government agency. So researchers conducted two best-worst scaling experiment methodology, which includes face-to-face interviews and assessment with the caregivers of children to really understand parents and caregivers' preferences and priorities for their children's ADHD treatment and outcomes. So they reported a lot of findings and results, but I'm highlighting the ones related to outcomes and endpoints they care about. So in terms of outcome priorities, the papers reported that the following is the most important to caregivers, as they report: child becoming a successful adult, school behavior improvements, and better grades, and etc. There were many others as well. Then I asked myself last week, are these events even feasible to be assessed within our traditional healthcare databases? I should admit that it's probably going to be challenging to find the appropriate fit for purpose data source in the US, but surprisingly, I came across several, not just few, several studies in other countries where they had excellent linkages between medical data and social functioning data, including academic achievement, such as finishing high school or going to college, and several papers on this in ADHD as well, kind of looking for their adulthood outcomes as well. So this does really highlight that it's not only up to individual small research teams in silos, but also that we need to have access to available infrastructure and platforms to be able to conduct these type of patient-centered, patient-informed, real-world evidence studies and designs, if you will. So let's go to the next slide for another use case. So as I mentioned, I had 4 use cases. So this is going to be the last, but not the least. But now let's discuss about how PPI can help interpret research findings from a traditional real-world data study on medication adherence. Large automated healthcare databases are frequently used to assess medication adherence patterns. These include duration of use, time to treatment discontinuation, medication possession ratio, proportion of days covered, and many others, parameters and algorithms that pharmacoepidemiology and outcomes researchers have created over the past several decades. Because these databases do have an excellent capture of prescription drug use. You have access to you have access to dispensing date, days of supply, molecular entity name, whether it's generic brand or whether the dosage and other related details and route of administration, if you will. But they do have limited data on reasons for treatment discontinuation, including medical and non-medical reasons. For example, a paper that I'm citing here assessing patients' reported reasons for treatment discontinuation showed that the reason for discontinuation actually differs across medication classes. So it's not uniform within the same indication and disease. Some more frequently due to loss of effectiveness, some more frequently due to side effects, and some more frequently due to cost-related non-medical reasons. So if you're going to suppose study comparative adherence across different medications within the same indication, this is something that PPI can help you understand if the different differential adherence levels that you see between different medication entities are really due to only medical or also due to non-medical reasons. So in another example, this time study conducted by CDC, they reported that among older adults with chronic diseases, about 6% of patients responded some sort of cost-related medication non-adherence, meaning non-medical related non-adherence reasons. So meaning that they skipped their doses, they took less medicine, or delayed filling a prescription to save money. You wouldn't necessarily get this information from traditional healthcare real-world databases, including claims or even electronic health records. But now knowing this information, being informed by patient-provided information, you may want to conduct additional analyses by adjusting by income, for example, at patient, if available, or at zip code level, or even to assess this issue directly by reaching out to representative sample of patients to really understand why some patients are discontinuing more than the others, and by medication entity or medication class across different indications. So I believe, as I mentioned, this was my last slide, but before turning over to Rachel for Q&A, I should add by concluding and saying that we don't know what we don't know, and to improve quality of real-world evidence study designs, it's always important to incorporate PPI in our research design and strategy. So thanks everyone for listening. And with that, back to you, Rachel.
Thank you very much. That was an excellent presentation, both of you. Thank you so much for all of those valuable insights into what really real-world data can reveal from an evidence standpoint to understand the full context behind the numbers that we're seeing. So now that we have concluded our presentations, we are now entertaining questions from the audience. Please submit your questions through the Q&A function here on Zoom, and we will verbalize your questions out loud for our panelists and presenters today. Now, while we wait for a few questions to roll into the Q&A, I can start off by asking our presenters one question. So, in your opinion, how can researchers who have not previously worked with patient organizations get connected with them to partner on research?
Sure, I'm happy to answer. And, you can always reach out to us at the National Health Council if you're doing a study about a particular disease area and you want to engage patients in it. We're happy to facilitate introductions. Or simply search and reach out to their research person. The patient community is really eager to get involved in research and share resources that they already have, share opportunities also to present your findings to patients as well.
Thank you so much. We have a few questions in the chat here. First of all, great presentation. Do you recommend performing some survey or qualitative research in addition to a real-world evidence study? I'll leave that to both of you to answer.
I can chime in first. I will say if you have resources and infrastructure, it will be good to do both, sometimes in parallel, and sometimes you may want to collect patient-provided information early on to help understand the design. But as I was trying to allude in my examples is that sometimes you may not have the time or you may not have the resources to conduct both, but that doesn't mean that you need to ignore patient-provided information completely. As I mentioned, some of the information, it may be already out there, so you don't need to repeat the same outreach and collect the same information from the patients. Of course, if the literature doesn't have the recent concurrent information, it's good to collect more, but most of the time you will be able to find, for example, the ADHD example that I mentioned. I was just asking a question randomly. Okay, I'm gonna establish an ADHD treatment outcomes and pattern study. And last weekend, I just looked at the literature and I saw tons of papers asking for caregivers and patients' input on what outcomes do they care about. So if you do not find anything in the literature, in those cases, I think it will be the most crucial and beneficial for your study and for your team to conduct them before in parallel. But in most of the cases, you probably will be able to find most of the information or some of the information already existing in the literature, if that helps.
I agree. And I'll just add, I think oftentimes what you might find is it's also unpublished. And so you're working in a company and you have a colleague who's working in the same topic as you might want to reach out to your folks who are working in clinical outcome assessment or patient-reported outcomes, because they might have that information, or teams working on patient preference research. Same thing if you want to reach out to folks who are at patient organizations. Many have registries and they may already know that information and be happy to share it with you, even if it's not public information at that time.
Yeah, I would agree with both of you. In my own work, I've realized that oftentimes it's the literature that informs a lot of some of the unanswered questions, at least in my mind or within my community, in which I'm conducting the actual research. And also, I agree that it's important to pay attention to even the literature gaps, because precisely that's where you might be able to inform the literature. And also, it'll allow you to at least know that before you can start answering more quantitative real-world data or evidence questions, there is utility in answering some qualitative aspects by either beginning a qualitative research study to begin with to, sort of level set around the topic, and also look into the literature to, again, identify some of the literature gaps to make sure that the work that you're doing is truly informing or enriching that gap. So thank you so much for your responses. We have another question in the chat here. We have a couple. Do you suggest any difference in study methodology for using electronic medical records for acute versus chronic disease, or other patient characteristics for study adherence?
I guess the question, it's a long one, so let me summarize this way. So there are, for adherence and for acute and long-term outcomes, is that the question, if I understood correctly?
Yeah, I'll repeat it again as it's written here in the chat. Do you suggest any difference in study methodology for using electronic medical records for acute versus chronic diseases, or other patient characteristics that examine study adherence?
Okay, so for acute events, probably, of course, it depends on the disease area or the exact study question. So it's hard to give high-level blanket recommendation at this point of time without going into the specific question. But I'm going to go back to the use case, for example, that I presented, so that we can enlighten on that. The statin example, right? That some patients were receiving samples. So that was a chronic condition, for example, and for anti-cholesterol medications. And usually for chronic conditions, and there must be a literature to support this as well, the samples are probably more given for chronic conditions, if you will, rather than if you're experiencing an acute severe event that you need to go to emergency department visit or hospitalization, if you will. So from that perspective, the patient provided information can be used differently to help understand some of the missing information. For example, in that anti-cholesterol medication, that PPI really help you to understand when to start your index date to look for adherence patterns or to look for outcomes for chronic medications, but probably that may not have been the case if you're really studying kind of acute event or acute treatments, such as for antibiotics. If your patient is infected with bacterials for a serious condition, I don't think the physicians or the patients will waste time with the samples. They will be immediately prescribed, what they need to get on the time, because it's a serious acute event, if you will. But for long-term conditions, sometimes samples may be tried to understand if the patient will tolerate for long-term treatment. So again, this was just one use case. This question is a big one because it can change depending on the question or the use case. But overall, of course, we expect different methodologies or approaches for chronic versus acute events, or EHR versus claims. Happy to discuss offline.
Thank you so much. Excellent response to that question. So there is one comment here in the chat for researchers who work for companies that have patient advocacy staff or who are involved in patient-focused drug development. They can turn to their internal colleagues who may have already collected some data. And that comment resonates with some of what was said already today. So thank you so much. And now an important question, at least from a patient advocate standpoint, how can researchers ensure that their study findings actually reach patients in the long run? So, when we say reach patients, that can look like different things. So I'll quickly turn it to our panelists to answer that question, and then we'll take more questions in the chat.
Great, thanks. Happy to take it. We did some work last year, actually the case example on AFib, where we had asked patients about how would you actually like to receive information. And what we found is, of course, for certain patients, they're going to go into the peer-reviewed literature and they're going to read the study and they'll understand it and they will use that information just like a clinician or a researcher might use that information. But what we also know is that for many patients, what they're going to rely on are the patient organizations or some type of support forum, whether that's an online forum or whether that's an in-person forum. And so to be able to also create some type of an infographic or something that's shareable can be really useful and doesn't cost a lot of money either. It can be, to make an infographic can cost less than the open access fees for a journal.
Definitely. What are your thoughts on that, Dr. Verjeux?
I will echo what Elizabeth had mentioned. I'm actually quite follower of National Health Council's projects, and they have done a lot of work on this work stream, and they have doing a lot of educational sessions about how to do this. So I think that organizations like NHC, Duke Margolis, and many others, if the more methods and more guidances if are to be developed, researchers will understand better about not just only publishing in a journal, but after that, how do you disseminate better these findings? That can be happening across multiple domains, including webinars like these, or in other public audiences to make it more layman language, if you will, not kind of scientific details, but overall high level. So it's also nice to actually, some journals have started doing that as well. Not only the kind of traditional abstract, but also having key points, very simple layman language about what your study found. So I think that journals need to pay attention to that as well. So it's not only for researchers alone, but the journals, the whole research society, if you will, need to pay attention to that, and we can work together to improve it further.
Thank you so much. So how can this information also be shared with institutional review boards who are even reviewing study proposals as well, in addition to the patients we talked about?
Sure. So we've, I know in work that I've done, I've just included in the background information, well, I guess it depends on what it is. There's the pieces that are about what's sort of the current landscape, and then you would certainly share that as part of your study protocol. But then you can also write about it when you're, defining variables or having to justify any type of study design decision if that's what you're trying to do with the information. So we've, certainly never run into any challenges from IRBs in terms of using this information and relying on the information.
I will let that patient confidentiality is also very important. One thing that we haven't mentioned in the use cases, when linking patient provided information to the actual healthcare databases, it is very important to make them in HIPAA compliant environment. So in terms of infrastructure, actually, I provided some use cases from European setting that, when they are linking social functioning with medical status of the patients for ADHD example, and they have very kind of HIPAA compliant, registry linkages. So I think it also requires infrastructure improvements in there as well in countries where we do not have such linkages, so that we can reliably and adequately and safely use patient provided information in our real-world evidence designs without sacrificing patient confidentiality.
Yeah. Now, thinking about research design, is there a design framework published somewhere that a real world evidence research design framework published somewhere that maybe one or both of you, rely on or use in your practice? Someone in the chat mentioned that it would be great to look at a larger graph to see those kinds of details.
Sure. So that was something that we developed as the advisory board, and then we asked the folks who participate in the interviews to refine the research design framework, and then we refined that. And that's actually what I presented today was the final one. But I think it can be a really valuable exercise or information also for students who might be just starting to learn about designing a study and who might benefit from an overview. So we do have it included in the white paper as an appendix, but if you reach out to me by email, I'm also happy to send you a PDF of it if you'd like to use it for another purpose.
Awesome. Thank you so much for that. Now, in your opinions or in your practice, both of you, what are the strengths and weaknesses of registries as sources of PPI? Someone has presented that question for you. And it
Okay.
looks like it was
Yep.
also partially answered in the Q&A, but I'd like to, give you guys the floor to talk about that a little bit more.
Sure, sounds good. I think that's an excellent question. I think registries have a lot of advantages, meaning that it's a registry of patients diagnosed with certain indication or condition, and you have direct access to them, and you can ask multiple questions and you can gather multiple information from them. So you can kind of collect patient-provided information in a structured format. That's a major advantage compared with, traditional claims-based data sources, if you will. Again, each data source also has to be fit for purpose for your research question. But I should also add that there are tons of registries out there as well. Just because it's a registry may not necessarily mean that it's a high quality registry. So I wouldn't necessarily jump into using registry over other data sources just because it's registry. So it's important to understand the quality of the data source that you're going to choose, whether it's claims or registry. But I should add that, overall, registries by design, because you have direct access to the patient, you are more likely to collect patient-provided information in a structured format. But it's good to pay attention to quality assessment of your data set before you select a single data source for your research question as kind of fit for purpose data source. So that will be my overall suggestion.
Completely agree. And I think many patient groups have their own registries, and it ranges from simple surveys to really sophisticated ones that are already linked to health systems. So definitely recommend taking a look at patient group websites for that reason as well.
Awesome. Thank you very much. And I also agree. I think the quality, as well as the depth of what the registry captures really depends on the patient's, disease focus. And really, it should be, in my opinion, and also in my practice, it should be tailored to the priorities of the patients and their day-to-day needs, their questions that probably have gone unanswered in the past. And also, it should be wired to capture the patient voice in ways that are effective down the line. For example, what are the proper endpoints? Both of you talked about that a bit. What are the patient-driven or patient-prioritized endpoints that should be captured in the process of trying to determine best next steps for the patient population? So thank you both for that. And to those of you, we did provide the link to the real world evidence classroom in the chat. So feel free to have a look. Feel free to ask us any questions that you might have after this session concludes. We do have 1 more minute before the session concludes. So I would like to open the floor for any last minute questions that we can collect and answer perhaps after the event, answer directly after the event concludes, or quickly while we still have a few seconds. But in any case, thank you for your feedback in both the Q&A and the chat. I see a comment here that the presentations today were excellent, and they clearly illustrate the value of taking a systematic approach for getting patient input to inform optimal design and interpretation of studies. So I agree with that comment, and thank you both for joining us today and presenting your very important work, very informative. And we look forward to engaging with everyone after this session concludes and any other events that we have moving forward.